Assalamu alaikum. I am Dr. Asfian Muhammad Zubairi, and I am going to present on the topic of diagnostic evaluation of BPH. As we have already studied about the anatomy and briefly about the pathology of prostate, we will just go for a quick overview of the different causes of lower urinary tract symptoms, as it is not just the prostate that causes lower urinary tract symptoms. They can be caused by other causes like the distal ureteric stone or a bladder tumor, urethral stricture, foreign body, a UTI, neurogenic bladder, nocturnal polyuria, chronic pelvic syndrome, or detrusor underactivity. So for evaluation of lower urinary tract symptoms in males, there are different tests that are performed, and the aim is to diagnose, monitor, assess the risk of disease progression or risk stratification, to plan treatment and to predict outcomes. Clinical assessment has two main objectives: identify the differential diagnosis and define the clinical profile. So the first thing that we need to do for evaluating a patient who comes with lower urinary tract symptoms, we need to take a good medical history, identify potential causes, relevant comorbidities, medical or a neurological disease, current medication that the patient is taking, his lifestyle habits, and emotional factors and psychological factors. EUA guidelines, the current guidelines, they strongly recommend that a complete medical history from the men should be obtained. So there are several symptom scores. After the history taking, we have to score the patient, we have to quantify his lower urinary tract symptoms, and there are several questionnaires that are available, and they are sensitive to symptom changes and can be used to monitor treatment. So one of the commonest that we use here is International Prostate Symptom Score. It has 8 questions in total. 7 questions are related to the symptoms, and 1 question is for the quality of life. Here is a picture of prostate symptom score. So we will briefly discuss this. We ask the patient if they have had a sensation of not emptying their bladder, such the incomplete bladder emptying. We score it from 0 to 5, where 0 being not at all, less than 1 in 5 times, and less than half the time, about half the time, and more than half, almost always. So the second question we ask the patient is if they had to urinate again in less than 2 hours for frequency, and if they had stopped and started again several times, to find out if they have intermittency, and we score it from 0 to 5. We ask them about if they find it difficult to postpone urination, if they have urgency. We score it from 0 to 5. Had a weak urinary stream, and if they had to strain while urinating, and the nocturia. Over the past month, how many times did they get up to urinate from time they went to bed? So this has the maximum score is 5 if they are going almost always for it. And the 8th question is for the quality of life. You ask the patient if they were to spend the rest of their life with the urinary condition that they have, how would they feel about it? Delighted, pleased, mostly satisfied, or mixed, about equally satisfied and dissatisfied, mostly dissatisfied, or unhappy, or terrible, being 6. So the total score that we have to score out of is 35, and the interpretation for IPSS is if a patient scores 0 points, he is asymptomatic. Mildly symptomatic would score from 1 to 7 points. Moderately symptomatic would be 8 to 19 points, and severely symptomatic patient would score from 20 to 35 points. There are limitations. You cannot. It lacks the IPSS score. It lacks the assessment of incontinence and post-micturition symptoms. There is another questionnaire that is developed for incontinence patients who have incontinence, and this is called the International Consultation on Incontinence Questionnaire. It is widely used and validated patient completed questionnaire. It contains 13 items. And there is another score which is called the Danish Prostate Symptom Score, and these two scores, they measure the bother of each individual lower urinary tract symptom. And the EUA recommends strongly that a validated symptom score questionnaire, including bother and quality of life assessment during the assessment of male lower urinary tract symptoms for re-evaluation during or after treatment. So the next step is we evaluate with use of frequency volume chart and bladder diary. Recording volume and time of each void by patient is basically a frequency volume chart, and including additional information such as fluid intake, use of pads, activities during recording, or symptom scores. That makes it a bladder diary. So the parameters that are derived from frequency volume chart and bladder diary include daytime and nighttime voiding frequency, total voided volume, fraction of urine production during night, and volume of individual voids. So the use of frequency volume chart may cause a bladder training effect and influence the frequency of nocturia, and the duration of bladder diary and FVC should be long enough to avoid sampling errors and short enough to avoid non-compliance. So it is recommended by EUA strongly that use of bladder diary to assess male urinary tract symptoms with a prominent storage component or nocturia, and tell the patient to complete a bladder diary for at least 3 days. So the next step after bladder diary and scoring, we come to physical examination. We have to focus on the suprapubic area, external genitalia, perineum, lower limbs for any neurological deficits. Exclude urethral discharge, meatal stenosis, phimosis, and penile cancer. Digital rectal examination is performed as we have discussed yesterday. The points that we note are the tone of anal sphincter, size of the prostate roughly, the surface, consistency, whether hard or rubbery, or rectal mucosa if it is mobile over the prostate or fixed, median sulcus if it is palpable or not palpable, upper limit if it is reachable or not reachable. So it is the simplest way to assess prostate volume, but correlation to actual prostate volume is not good. TRUS is a more reliable investigation in estimating prostate volume, and in a study it was revealed that underestimation of prostate volume with DRE increases with increasing TRUS volume, and EUA strongly recommends to perform a physical examination including DRE in the assessment of male lower urinary tract symptoms. So next is urinalysis. Dipstick or sediment must be included in the primary evaluation of patients presenting with LUTS to exclude UTI, microhematuria, or diabetes that may also result in such symptoms. So it is strongly recommended by EUA to use urinalysis in the assessment of lower urinary tract symptoms in males. Prostate-specific antigen is also measured. It has a good predictive value for assessing prostate volume and is a strong predictor of prostate growth. Positive predictive value of PSA for detection of benign prostatic obstruction was recently shown to be 68%. And there was an approximate criteria, age-specific criteria for detecting men with prostate glands exceeding 40 ml. If it is PSA is more than 1.6 in age 50, or if it is more than 2 nanograms in age 60, or more than 3 in age 70, it is an approximate criteria which tells us if the prostate is exceeding 40 ml. So EUA recommends that PSA should be measured if a diagnosis of prostate cancer is suspected, and we have to measure PSA if it assists in the treatment or decision-making process. Renal function measurements. is also a part of evaluating a patient with lower urinary tract symptoms. Renal functions may be assessed by creatinine or estimated GFR. Patients with renal insufficiency are at increased risk of developing post-op complications, and it is strongly recommended by AUA guidelines to assess renal functions if renal impairment is suspected based on history and clinical examination, or in the presence of hydronephrosis when considering surgical treatment for male lower urinary tract symptoms. Post-void residual urine is also measured, and it can be assessed by a trans-abdominal ultrasound or a bladder scan or catheterization. High post-void residual volume is not necessarily associated with bladder outlet obstruction. It can also be a consequence of detrusor underactivity. So monitoring of changes in post-void residual volume over time also allows identification of patients who are at risk of acute urinary retention, and particularly those on antimuscarinic medication. And due to large test and retest variability, there is no threshold decided for making treatment decision based on post-void residual volume. And it is weakly recommended by EUA that a post-void residual volume be measured for assessment of male lower urinary tract symptoms. The next evaluation we do is through uroflowmetry. Urinary flow rate assessment is a non-invasive urodynamic test, and the parameters should preferably be evaluated if the voided volume is more than 150 ml. This is how a UFM curve normally looks like, and on the y-axis we can see the flow rate, which is in milliliters per second. X-axis is the time to achieve that flow, and this is a bell-shaped curve which is normally, and the peak is the maximum flow rate. Low Qmax can arise as a consequence of bladder outlet obstruction, detrusor underactivity, or an underfilled bladder. And uroflowmetry can be used for monitoring treatment outcomes and correlating symptoms with objective findings. So to perform uroflowmetry in the initial assessment of male lower urinary tract symptoms is weakly recommended by EUA, whereas to perform uroflowmetry prior to medical or invasive treatment is a strong recommendation by EUA. The next step is imaging. So we image the upper tract in men with LUTs. Men with LUTs are usually not at increased risk of upper tract abnormalities or malignancy. It can be used for evaluation of men with large post-void residue to see any hydronephrosis or any vesico-ureteric reflux, in patients with hematuria, or in patients who have a history of urolithiasis and who have now presented with LUTs. So it is a weak recommendation to perform ultrasound of the upper urinary tract in men with lower urinary tract symptoms. Sorry. Next step is imaging the prostate, and imaging of prostate can be performed by transabdominal ultrasound, transrectal ultrasound, CT and MRI. Assessment of prostate size is important for selection of interventional treatment and prior to starting treatment with 5-alpha reductase inhibitors. It is to perform imaging of prostate when considering medical treatment of male lower urinary tract symptoms. If it assists in the choice of the appropriate drug, is a weak recommendation, and performing imaging of the prostate when considering surgical treatment is strongly recommended by EUA. The next imaging investigation is voiding cystourethrogram. Voiding cystourethrogram is not recommended in the routine diagnostic workup of men with lower urinary tract symptoms. It may be useful for the detection of vesico-ureteric reflux, bladder diverticula, or urethral pathologies. And retrograde urethrophy may additionally be useful for evaluation of urethral strictures if they are suspected. Urethrocytoscopy is performed for diagnostic evaluation of patients with a history of microscopic or gross hematuria, urethral stricture, or bladder cancer who present with LUTs. Urodynamic studies in male lower urinary tract symptoms. Most widespread invasive urodynamic technique is employed are filling cystometry and pressure flow studies. The major goal is to explore functional mechanisms of LUTs, identify risk factors for adverse outcomes, and provide information for shared decision making. So in urodynamics, we can differentiate between a bladder outlet obstruction, which basically results in increased detrusor pressure with decreased urine flow rate, and the detrusor underactivity, which results in decreased pressure of detrusor and decreased urine flow rate. There are other non-invasive tests which include intravesical prostatic protrusion, or bladder or detrusal wall thickness, and ultrasound estimated bladder weight, and non-invasive pressure flow testing. And it is recommended strongly to not offer non-invasive tests as an alternative to pressure flow studies for diagnosing bladder outlet obstruction. So intravesical prostatic protrusion basically is an ultrasound measure of to assess the distance between tip of the prostate median lobe and bladder neck in the mid-sagittal plane, using a suprapubically positioned ultrasound probe with a bladder that is filled up to 150 to 250 ml. So this is basically a picture of that shows the prostate protruding. This is taken from mid-sagittal view, where prostate is protruding into the bladder, and there are different grades of this IPP. For grade 1 is from 0 to 5, more than 5 mm. If the protrusion of median lobe is more than 5 mm, then it is grade 2, and if it is more than 10, it is grade 3 intravesical prostatic protrusion. This is basically the assessment algorithm for lower urinary tract symptoms in men. And if a patient presents with lower urinary tract symptoms, we can see here we have to start with a history, then move on to a symptom score, then urinalysis, physical examination including DRE, and PSA if a diagnosis of CA prostate is suspected, and measurement of post-void residual volume. If there is significant post-void residual volume, then we go for ultrasound plus minus renal function assessment. If there are bothersome symptoms, then we go for a frequency volume chart, and we also go for ultrasound assessment of prostate and uroflowmetry. And later we can move on to, if there is a benign condition of bladder or prostate, then we can plan treatment, which will be discussed in the next session, or medical treatment or surgical treatment. And if the DRE findings are abnormal on the extreme left, and we suspect a neurological disease, high PSA, abnormal urinalysis, then we evaluate according to the relevant guidelines. This is the end of my presentation. Thank you.